evening, everyone. Today I'm going to present my seminar on the surgical management of thyroid cancer. So, to begin with the introduction, differentiated thyroid cancer includes papillary, follicular, and follicular cancers, which comprises more than 90% of all thyroid cancers. These two entities share similar diagnostic and treatment algorithms and have an overall excellent prognosis at 5 years when diagnosed and treated appropriately. Surgery is the mainstay treatment of DTC. So, to classify the thyroid mass can be classified as benign and malignant. So, the differentiated thyroid cancer belongs to the malignant category, which are derived from the follicular cells, which further is divided into differentiated and undifferentiated. So, differentiated includes follicular, papillary, and Hurther cell, and undifferentiated is anaplastic. Histologic distribution. So, approximately 78% of the cancers are papillary, followed by follicular, which is 13%, and Hurther cell 3%, medullary 4%, and anaplastic 2%. So, all these differentiated thyroid cancers are malignant and belong to the category Bethesda category 6. So, this is the recent AGCC 8 edition, where the definition of primary tumor and regional lymph node metastasis are mentioned. So, the tumor with more than 4 centimeter and limited to thyroid, is classified as T3A, and with gross thyroidal extension invading only strap muscles of any size is T4B. Beyond strap muscles, it is T4A, and in invading prevertebral fascia is T4B. Again, central compartment level 6 or 7 involvement is N1A, and unilateral or bilateral contralateral lymph nodes are 1B. So, in this classification, the definition of age at diagnosis was changed from 45 to 55 years, and accordingly, the prognostic stage groups were for less than 55 years. NET, NEN without distant mets is what is stage 1, and less than 55 years with distant mets is stage 2, and rest for more than 55 years, the staging is described accordingly. So, in this article, the age threshold of 8th edition AGCC classification, the basic motive was that 8th edition of AGCC has decided to increase the cutoff age for risk stratification in papillary thyroid carcinoma from 45 to 50 years. In this study, they assessed how well this new age threshold stratifies patients with aggressive PTC. So, this was a retrospective analysis, the clinico-pathological features and overall survival rate with PTC admitted to and surgically treated at one single center. The patients were divided into two groups. With the first series was cutoff. In first series, the cutoff was like less than 45 and more than 45, and in the second group, it was less than 55 or more than 55. The rate of results, the rate of prevalence of locally advanced disease, that is PT3 or T4, was significantly higher in patients above 55-year-old than those in below 55-year-old. So, there was no significant difference found in this parameter in the series for with cutoff of 45-year-old. So, to conclude, the age cutoff of 55 years for risk stratification proposed by the 8th edition effectively stratifies patients with poor prognosis, indicating it is likely to be useful in clinical practice. So, what are the goals of the treatment? It is to remove the primary tumor, minimize the recurrence, and minimize the metastatic spread, facilitate to post-operative treatment with RAI whenever indicated, permit accurate staging and risk stratification, permit accurate long-term surveillance for disease recurrence, and minimize treatment-related morbidity. So, what are the surgical options for the management of DTC? So, hemithyroidectomy, which includes the involvement of one complete lobe with isthmus. Total thyroidectomy involves the complete both lobes of thyroid, and near total thyroidectomy, some portion of the thyroid bilaterally or unilaterally is left behind. So, according to the ATA guidelines 2015, differentiated thyroid cancer, if they are divided into three categories, that is less than 1 centimeter, 1 to 4 centimeter, more than 4 centimeter. So, for 1 centimeter, if there is no extrathyroidal extension, clinically N0, no history of radiation or follicular thyroid carcinoma, then total thyroidectomy or a unilateral procedure, that is hemithyroidectomy or lobectomy is advised. If the tumor is more than 4 centimeter with gross ET, CT4, CN1, and along with distant mets, total thyroidectomy and gross removal of all of the primary tumor is suggested by the ATA. So, coming to the most controversial part is tumors for 1 to 4 centimeter. So, in this category, if there is no adverse features, that is no extrathyroidal extension, clinically it is N0 in central compartment or no lateral nodes. So, unilateral hemithyroidectomy or lobectomy is advised. If there is a gross adverse features present with nodal disease, then total thyroidectomy is advised. This article, which is extent of surgery affects survival for papillary thyroid cancer. This included 52,173 patients diagnosed between 1985 and 1998. 43,000 patients received total thyroidectomy and 88,900 patients received lobectomy. So, papillary thyroid carcinoma less than 1 centimeter, extent of surgery did not impact recurrence or survival. For tumors that were more than 1 centimeter, lobectomy resulted in higher risk of recurrence and death. So, the study demonstrated a slightly higher 10-year overall survival for total thyroidectomy when compared to lobectomy. That was 98.4% and 97.1% respectively. There was slightly lower 10-year recurrence rate for total thyroidectomy, 7.7%. To conclude that total thyroidectomy resulted in lower recurrence rate and improved survival for tumors that were more than 1 centimeter when compared to lobectomy. This another study, overall and cause-specific survival for patients undergoing lobectomy, near total or total thyroidectomy for differentiated thyroid cancer, included 23,605 patients. Approximately 12,500 patients received total thyroidectomy and 3,266 patients received lobectomy. Again, the overall survival rate was not, there was statistically no significant difference was found. Level was also same, 96 similar, 96.8 for total thyroidectomy and 98.6 for lobectomy. So this article by Ito et al. Is low risk papillary microcarcinoma of thyroid, a review for active surveillance trials. So papillary microcarcinoma are defined as tumors that are less than 1 centimeter in greatest dimension. They concluded that active surveillance is the optimal first line of management for all adult patients with low risk microcarcinomas. The accumulated data indicate that observation can be applied for all other patients with low risk microcarcinomas regardless of background factors such as age, gender and family history. When to go for completion thyroidectomy? According to the ATA guidelines recommendation, completion thyroidectomy should be offered to a patient for whom bilateral thyroidectomy would have been recommended had the diagnosis been available before the initial surgery. So, if we have to do the completion thyroidectomy, we should do this procedure within 8 weeks of histological diagnosis following the initial surgery. And the main aim of this procedure is to provide the complete resection of the multicentric disease and to allow for efficient radioactive iodine therapy. So this is the ATA guidelines for the neck dissection. In this we have simplified. So when to go with therapeutics central compartment with clinically involved level 6 nodes, there should be therapeutic neck central compartment clearance, and prophylactic central compartment was suggested when it is clinically N0 with advanced T3, T4 tumor or clinically CN1 disease. For lateral neck, only therapeutic neck dissection is suggested by the ATA guidelines, that is biopsy proven metastatic cervical lymph nodes. The guidelines clearly mentions that no prophylactic lateral neck dissection should be done. So, in this article by Brzezinski et al., prophylactic central neck dissection for papillary thyroid cancer, it was a retrospective cohort study to evaluate whether prophylactic central neck dissection for PTC affected long-term survival and loco-regional control. 640 patients were included, and 282 had total thyroidectomy without CND, and 350 had total thyroidectomy with the central neck dissection. 10 years disease-specific survival rate for patients who had total thyroidectomy without CND was 92.5% versus 98% with CND. Locoregional control was also better in patients who had total thyroidectomy with central neck dissection. It was 94.5%. Again, by this study by Zio et al., central lymph node metastasis, whether it was a reliable indicator. It was also a retrospective study consisting of 121 patients with papillary thyroid carcinoma who underwent ipsilateral selective neck dissection. The quantitative relationship between central and lateral lymph node was analyzed. So they concluded that sensitivity of the central node involvement to predict lateral lymph node metastasis was 85.9% and specificity was 61.4%. Also, when there were 2 or more positive central nodes, neck was 20.5%, and when there was 1 central node, it was 47.4% respectively. Again, this article by Oshima et al., indications for bilateral modified radical neck dissection. It was published in 2000, in the year 2000, with papillary carcinoma of thyroid. The main purpose of this study was that after subtotal thyroidectomy with modified radical neck dissection of the affected site, nodal recurrence at the contralateral side indicates a poor prognosis for the patient. So bilateral modified radical neck dissection, whether it is beneficial for high-risk patient and in respect to contralateral nodal recurrence. It was also a retrospective study from January 1, 1970 to December 1, 1995 in Japan, and approximately 1776 patients having tumors greater than 1 centimeter in maximum diameter who underwent thyroidectomy and ipsilateral modified lateral leg dissection with curative intent. Results showed that 32 patients developed contralateral lymph node metastasis during the mean follow-up period of 12.1 years. The risk factor for contralateral nodal recurrence were male gender, large primary tumor, tumor extension over isthmus, extracapsular adhesion or invasion to surrounding tissues, and presence of gross nodal metastasis at initial surgery. This patient had a greater number of distant metastasis, that is 31.1%, and a lower 10-year survival rate as compared to patients without nodal recurrence. So they concluded that bilateral modified radical neck dissection should be considered for patient with papillary carcinoma who shows risk factors for contralateral nodal recurrence, as it could prevent second operation and may improve the outcome. Again, coming to the initial risk stratification for differential thyroid cancer. So the first staging system was developed, suggested by EORTC in 1975, which included male gender, histology, tumor staging, and distant metastasis. Again, there are these all AIMS, ages, MASIX, and GAMES. All this basically took into consideration age, grade of tumor, extrathyroidal extension, size of tumor, and the distant metastasis. Only MASIX also took into consideration the completeness of surgical resection and invasion. However, all these prognostic indicators had a few shortcomings, like reporting of tumor for PTC in case of ages was variable among the pathologists, and it was available only after the initial surgery. For AIMS classification, the data was retrospective. the earlier cases were incomplete in respect to tumor size, and this study included both FTC and PTC trials. So, what was the need for the? There was a need for the universally accepted risk stratification system, as mentioned earlier. Shortcomings based on the retrospective data from single institutions, the earlier classifications, and there was no proven advantages over the universally used TNM system. A study that classified 269 patients with papillary thyroid carcinoma according to 5 different prognostic paradigms found that some patient in the lowest group from each group died of cancer. So TNM predicts cancer mortality reasonably well, and TNM staging was not established as a predictor of recurrence. So to overcome all these shortcomings, there was a need for a universally accepted initial risk stratification system, a 3-tiered staging system that uses clinico-pathological features to risk stratify was adopted in ATA guidelines 2009. The goal was effectively the goal of this stratification system was that it effectively risk stratify patient with regard to risk of recurrence, persistent disease after initial therapy, risk of having persistent structural disease, likelihood of achieving remission in response to initial therapy, and likelihood of being in remission at final follow-up. So there are 3 levels that divided. This classification is divided into 3 levels: low risk, intermediate risk, high risk. Low risk includes no local or distant metastasis, complete resection of all the disease. There is no gross disease, no loco-regional invasion. Tumor does not have aggressive histology. There is no vascular invasion and no iodine uptake outside thyroid bed on first post-treatment whole body RAI scan. In intermediate risk, microscopic invasion into the perithyroidal soft tissues, cervical lymph node metastasis, and aggressive histology or vascular invasion, and iodine uptake outside the thyroid bed is present. In the high risk, there is gross tumor invasion, complete tumor resection, distant metastasis, and thyroglobinuria out of proportion for post-treatment scan. So this is the again what we have discussed in the earlier table. This is in detail ETA 2000 risk stratification system proposed for modifications. Here it is in this picture. It is risk again adopted from ATA guidelines 2009. Risk stratification of structural disease recurrence in patients without structurally identifiable disease after initial therapy. On the left hand side, we have the 3-tiered risk system proposed as initial risk stratification, that is low risk, intermediate risk, high risk. And on the right hand side, we have risk of structural disease recurrence associated with selected clinico-pathological features mentioned with percentage. So we can see that unifocal microcarcinomas have least chances of recurrence, that is 1 to 2%. It increases with when there is multifocal microcarcinomas, 4 to 6%, and it is highest when there is like a PT1 extranodal extension gross T-fold tumor with gross ET, and highest in the follicular thyroid carcinoma FTC with extensive vascular invasion, that is 30 to 55%. Thank you.
So Vijay, like as you told, which cases you will go for total thyroidectomy? Like what are the indication of doing total thyroidectomy? Like in those cases, you will not think twice that you will be doing a hemi or near total or whatever. So what are the yes?
Sorry, sir, you can complete the question.
My question is that yes, what are the absolute indication of doing total thyroidectomy?
Sir, the cases where there is gross extrathyroidal extension with tumor more than 4 centimeter, invading the surrounding structures, all these are clear-cut indications for total thyroidectomy.
Apart from this size criteria, any other thing?
Sir, age also age is a factor then. which is also a risk factor. And nodal recurrence, nodal metastasis.
Okay.
Yes, sir.
Apart from this, anything, Surbhi or Rizul? One is your, if there is known distant metastasis. Okay. Yes, Surbhi?
So in high risk cases like in history of radiation exposure, family history, size more than 4 centimeter, T3, T4 diseases.
Okay. And if your histology is like in like you're getting, if it is a tall cell variant, columnar cell variant, or poorly differentiated thyroid cancer, so these are the indication of total thyroidectomy. Okay, and like what are the indications of doing a prophylactic central compartment dissection?
It is clinically if there is a suspected gross extension of the disease, clinically involved lymph nodes, the poor histology of the disease.
I am just asking you about the prophylactic level 6 dissection. One is there like where you will be doing, and in those cases, no, like where there are suppose no nodes, but still there is indication of doing.
So, the patient with the adverse features like tumor size, tumor histology, and papillary.
When there is suspicious of this medullary component.
Sorry, sir.
When there is suspicious of medullary.
Yes.
Okay, of course. In the medullary we do. So, what the literature says, no, like one is your if it is a T3 or T4 disease, even if there is no nodes, then in those cases we can go for the prophylactic central compartment dissection. But like if there are small disease T1, T2, clinically node negative, and most of like your follicular cancer, then in those cases, and the surgeon is also not much experienced. Then in that case, like we can like leave it. But generally, in case of, as you're right, medullary CA or T3, T4 disease, then in cases like we will be doing the prophylactic your level 6 dissection.
Yes.
Okay. So, have you read about this tennis syndrome? I think your topic is just about the surgical management, no?
Yes, sir. Surgical management of differentiated thyroid cancers.
So, like you were talking about the Hurthal cell carcinoma. So, do you know what is it, Hurthal cell carcinoma, and how do you define it, and how it is different from other differentiated thyroid cancers? If you are right, you are going on the right direction. So the Hurthal cell is basically a histological diagnosis, no? Because there is a concentration of eosinophilic cells, there is a high concentration of eosinophil. So the Hurthal cell. Hurthal cell is a type of which cancer? Papillary or follicular?
Follicular.
Does it hold true in case of thyroid also? Is nodal
they do not impact the overall outcome for the patient. Like in case of follicular thyroid carcinoma, the most
ಮಾತ್ರ ಕೇಳ್ತೀನಿ ನೋಡಿ ಇದು DTC ಇದು ಮಾಡ್ತಾರೆ. ಇದನ್ನೇ ಕಳಿಸ್ತೀನಿ ಒಳ್ಳೆ ನನಗೆ ಹೇಳ್ತೀನಿ ನೋಡು ಇವಾಗ. Dr. Tejas Nagireddy, do you have some question? Or I think your mic got just switched on. Please continue, Dr. Vijay.
Yes, sir. So the nodal recurrence does not impact the overall outcome like in follicular thyroid cancer. The most of the the outcome is impacted by the distant meds. So nodal
Does it
recurrence
hold-
does not.
Does it hold true for every patient, or is there some like line of demarcation that there is some age criteria? Like it has no
So
significance.
definitely the extreme ages, extreme ages have more worst outcomes.
So you're right. Like in your extreme ages, like in your younger or in
Too young
your
or
extremity
too
of-
old.
in that case, it does have your survival or your loco-regional indication and significance, but
Yes.
otherwise it doesn't have.
Yes. So sir,
And what is its implication?
Sir, N0A is no evidence of benign. That is a benign disease, benign node. And N0B is N0B is
इससे पूछ रहे हो?
नहीं, इसी से नहीं सर.
What is N0A? What is N0B?
Sir, N0A is there is a benign lymph node, and N0B is there is some evidence of lymph node metastasis.
Are you sure?
Sorry, no evidence of metastasis.
So what is the difference between these two? I didn't get it. Did anyone else get it? Dr. Survi, did you get what he was trying to say?
So in N0, it is histologically proven that nodes are benign, and N0 and B, it is clinico-radiologically proven that there is no node in neck.
Okay. So basically, N0B is a higher stage as compared to N0A. So it means that suppose we have done total thyroidectomy, and many a times some lymph nodes can be removed accidentally, or maybe we feel that okay, looks something suspicious. Why not do maybe T2 borderline region is bordering T2 or T3, and many a times central neck dissection is done, and if that comes out to be negative versus something which is just clinico-radiologically proven negative. Okay. So one which is pathologically proven negative holds more significance versus something which is only radiologically
or clinical.
Okay. Because this is going to help us in decision making regarding RAI as well. Okay. So once it is proven that there is no lymph node metastasis in a T2 lesion, we are sure that okay, we can avoid going ahead with radioactive. Okay. So you spoke about risk stratification, right?
Yes.
So what is when you start treating a thyroid patient? What is the first risk stratification which is made during the management line, treatment line, which we usually do in our clinics?
Sir, I didn't get the question. Sorry.
So what are the different types of risk stratification in thyroid cancer management?
Sir, it is like a low risk, intermediate risk, high risk.
No, different types means at what stages of treatment line, management line, do you risk stratify the patient for the thyroid cancer patient?
Sir, after we get the histopathological report.
Before histopathological report, do we risk stratify the patient?
Yes, sir. It can be according to the features of the disease, like tumor size, grade.
So, can you give me an example where we always risk stratify the patient before planning our treatment line? We always do that in our clinic. Can you say the name of that risk stratification method? You have discussed about it in your presentation.
AGs.
AJ? No. Do we do AGs regularly? What do we do? How do we risk stratify before starting the treatment?
So, considering the age factor, gender, the features of the disease.
So what is it called? इसको क्या बोलते हैं? So the staging that you do is the first risk stratification. Okay.
Okay, sir.
The TNM staging is the risk stratification. It risk stratifies the chances of mortality.
Yes, sir.
Okay.
Yes.
What is the next risk stratification? After that, the second stage where you risk stratify. You were correct. You were saying something about after surgery.
Aims and aids.
With the histopathological report.
Perfect. So someone said AIMS and ages, right?
Yes, sir.
So what is AIMES and what is AGES? Can someone complete it for me?
A stands for age, G stands for gender,
G.
E stands for extent, and S stands for size of tumor.
Perfect. So AGES is a risk stratification which is done before surgery. So it was used before TNM staging came into being. Getting my point?
Yes.
For thyroid cancer, before TNM staging became a routine thing, AJs, AMAs, and some other AES classification was there. Yes. The only classification which took surgery into account was, can anyone complete?
Masses.
Masses classification, which the full form is, please complete.
Metastasis.
Perfect. Perfect.
Like completeness of the surgical resection.
Perfect. Perfect. And
size.
Extrathyroid extension and size of the tumor. So it was the only risk stratification system which took into account the role of surgery and its impact on the outcome.
Yes.
Okay. But the evidence was not very strong. In the sense it was just backed by one institute. And eventually we got this idea that, okay, completeness of surgery also holds very important role in our outcome of treatment, right?
Yes, sir.
And hence, eventually, 2 more stages of risk stratification came into being, which are, please complete, called as
games.
The initial risk stratification. So this is which we presented just now, the continuum of risk stratification. Okay? Yes. That is initial risk stratification post-surgery. Getting the point?
Yes, sir.
So see, there are some additional factors which have been taken into account in present scenario, and that includes some genetic permutation combination as well, right?
Yes.
So BRAF mutation is something which you must not neglect while taking this decision making, discussing this concept. Okay. So BRAF mutation per se is not a standard of care, not a routine of care everywhere, right? But if you have it available in your center, please do use it in initial risk stratification post your surgery, right? Now, after this initial risk stratification, when you have already risk stratified your patient, what is the next risk stratification which comes into being, and what is this called?
Anyone else? Dynamic risk stratification, which is adapted according to
very good. Very good, very good. So after that, so initial risk stratification tells you that what are the chances of recurrence in this patient, and it will help you in deciding your adjuvant therapy, whether it is required or not. Getting the point?
Okay.
So once you have dealt with your initial risk stratification, so this initial risk stratification basically means your initial risk stratification post-surgery. Now we are talking about post-surgery, okay?
Yes.
I'll tell you why it is called as initial risk stratification, because it is the initial part of risk stratification of the follow-up. Okay?
Yes.
So it helps you in deciding the need for radioactive iodine or maybe radiation therapy if required in differentiated thyroid cancer also, right?
Yes.
So once you have completed your treatment line, now what you do, you continue with your follow-up. Okay?
Yes, sir.
Then comes the role of dynamic risk stratification. What is this dynamic risk stratification? Whenever the patient comes to you in your follow-up, you will assess the patient and you will risk stratify the patient. And this dynamic risk stratification means that the status of the patient changes, which means the chances of mortality or the chances of disease recurrence for the patient changes as the patient continues in his line of treatment. So suppose a patient which was initially T1, T2, N0, initially risk stratified low risk,
Yes, sir.
is in follow-up, now comes with some kind of either elevated thyroglobulin or some kind of structural nodal disease somewhere. So now this patient will either become structural incomplete recurrence or can someone complete it for me? Dr. Rizul? Dr. Surbi, Dr. Shikha, Dr. Jasdeep, anyone?
So biochemical structural response.
Very good. So either it will be structural incomplete response or biochemical incomplete response. Okay, so we'll discuss about this dynamic stratification later on in detail. Okay.
Yes.
But some things which we have to understand is that now the terminology is shifting towards unifying the terms in one direction. Okay.
Yes, sir.
So suppose we discuss, we'll discuss about this dynamic stratification later on because it is a whole new topic, detailed topic. One more thing.
Yes, sir.
Doing lateral neck dissection. Okay.
Yes.
So can you justify doing lateral neck dissection in a patient with high central nodal tumor burden?
Yes, sir.
So justify.
Because sir, the chances of lateral lymph node involvement when there is clinically involved central compartment is like the I'm not sure about the exact percentage, not recollecting.
So, but if the central compartment is positive, the
Yes.
chances of it being positive are high. Okay?
Yes, sir.
But we have clinico-radiologically no disease over there. So it is an occult nodal metastasis, right?
Yes, sir.
So can we not give RAI and treat it? We are anyways going to give RAI to our patient who is having central nodal positivity, right? And we are really not sure whether that is going to be positive or not. So is there any issue with RAI tackling that disease?
Sir, the monitoring will be difficult, sir, if it is not visible in pre-op scan. If we leave it like that, post-op it will be again difficult to monitor it.
I get your point. It will be difficult to monitor, but if the size increases, we'll be able to monitor it, right?
Yes, sir. Yes. But if initially we didn't pick up, so for some more time it will be again difficult till it becomes significant. At that time, it will be too big.
True. Great. So one point is that there will be chances of nodal metastasis. The question I was asking that even we are already giving RAI, so why not let RAI tackle that micrometastasis, right? The thing is that the nodal nodes have a really low radioactive iodine avidity, even in presence of metastatic thyroid tissue over there. Take care. The avidity is as low as 20% compared to a normal thyroid tissue, right? So that can lead to a reduced uptake over there and hence reduced disease in reduction in disease burden. So these are some of the important concepts which we have to understand. The thyroid is a very vast topic. It is more about treatment philosophy in thyroid. Otherwise, total thyroidectomy, bilateral neck and bilateral central compartment, sab kahani khatam, right?
Yes.
So we have to understand the philosophy and concept about it. And
Sir, ipsilateral central compartment is is there any evidence or was we are doing in a practice ki ipsilateral positive आएगा then will we address opposite central compartment?
Ipsilateral अगर positive आएगा then we will address. So if it is ipsilateral positive, the chances of contralateral positive, central compartment now, ipsilateral and contralateral distinction is not anatomical. Okay? And the nodal metastasis to both ipsilateral and contralateral nodes is present from both the lower lobes, inferior pole, as well as the central thymus portion, central क्या बोलते हैं उसको, isthmus portion. Okay. But if the ipsilateral is positive, the chances of contralateral nodal positivity are very high. The morbidity is not really high if you are routinely doing central compartment neck dissection. Okay. So there is no question about it. If it is ipsilateral positive, you have to do contralateral central compartment, and you should address ipsilateral lateral compartment as well.
Okay. So in case if this central compartment ipsilaterally dissected, it comes out to be negative, then we should not address opposite, because you are saying कि anatomically it's not पहले से defined नहीं है, it's a central compartment itself is a one compartment only, so we can leave opposite side.
Yes, you can. If it is negative, you can leave opposite side.
And one reason can also we give, sir, for that when central is positive, why we are doing lateral leg dissection. Can we say like that we discussed recently, N0A, like nodes we dissected, it is negative, then it is good prognostic. It will help in deciding the adjoint, whatever radioactive iodine or ablation, what we need to do.
Okay, so you're absolutely correct. So you want to say that if central is positive, and we are doing lateral compartment, can we justify it by saying that it will help us in prognostication and proper staging of the early part of the disease? You're absolutely correct. So that is an important aspect of any prophylactic neck dissection. Whenever you are doing prophylactic neck dissection is not only therapeutic, and I always repeat this, I have repeated this many times in my OPDs also. Any kind of prophylactic neck dissection is not only therapeutic, it is diagnostic as well. It also helps us in staging the disease. So it has got twofold benefit. You take it in oral cancer, you take it in thyroid cancer, anywhere. Prophylactic dissection, take it groin cancer, groin dissection, dissection. Prophylactic dissection helps, it is therapeutic as well as diagnostic, isn't it?
Yes. And sir, in this staging also, there is more than 5 lymph nodes are positive, then only it's come in the intermediate or high grade.
Absolutely. So more than 5 lymph nodes, they come for intermediate risk. Single lymph node also you can consider intermediate risk if the size of the nodal metastasis is big. So if it is a micrometastatic foci in a single node versus there is a 4 centimeter node in the central compartment. Okay. The 4 centimeter node, even if single node, so it is not given in your ATA guidelines, but if you read in detail in those papers which are talking about it, so a large node can also put it in the intermediate risk for high risk. Okay?
Okay, sir.
Azun question? Cross-sectional imaging, right? So if you are going ahead, go ahead and do a proper central compartment, okay? Or else trust your imaging and go ahead with that. Because central compartment sampling is being done at a lot of places, but it is really not very beneficial in detecting the metastasis. So suppose you did central compartment sampling and you found out one lymph node positive. It is really not going to change your prognosis, right? It can help you in decision making at that point of time, but it's a double-edged sword. See, if you have violated the central compartment sample, neck, okay, you sent it for shows and it didn't come positive, then you see in final HPI that there is a node or 2 nodes positive. So you have already violated the central compartment, okay, and now you don't know whether you should go in and do a revision central compartment or not. Okay, so if you are entering into central compartment, better you do a proper work. सब कुछ clean करके आराम से आ जाओ. There will not be any nerve damage. Try to preserve your superior parathyroid because inferior parathyroids are bound to be damaged. Their vascularity gets slipped. And coming on to the question of lateral compartment, this is something where we should already decide before entering. We should not leave the decision of central compartment based on our intraoperative failure. Sorry, lateral compartment based on our intraoperative failure.
Sir, once upon a time we operated here only. One case was there. It was only 2 centimeter papillary thyroid cancer, but it was peripheral of the lobe, so we can see that nodule. So we just send prophylactic central compartment. It comes out to be positive. We completed full. After that, we address lateral also, but it was only 2 centimeter. And in lateral compartment also it came positive, but the nodes were not so big. They were very small, and we were not able to differentiate in the tissue ki they are many separate nodes, but they came out to positive. And then we closed because we were thinking ki it won't be positive, and then again we need to open and address level 5 because 2 3 4 also came out to be positive. तो I don't know, मेरा तो एक ही ऐसा देखा है.
So no, so that is why thyroid is a very interesting disease, right? And that there's so much of literature on thyroid, because there is variability in disease presentation and variability in disease management, right? You are talking about a 2 centimeter nodule, but we know that microcarcinoma showing up a lateral neck metastasis is not uncommon, right? You will see lateral neck large nodal disease with just less than 1 centimeter or maybe no thyroid disease at all. Okay, you will do many a times thyroidectomy because lateral neck has come out to be positive for thyroid. So these are common scenarios. These can happen. And it is a good thing that you addressed lateral neck and then you went ahead and did level 5 negation as well. You helped the patient. You should be proud of that.
Hello? Sir, again, one more question, sir. When we do the, after follow, after doing the surgery and adjuvant radioiodine ablation, also, when the patient came with the follow-up, if there is a small, less than 1 centimeter nodule on the lateral compartment, so as ATA guidelines says the lateral compartment is more than 1 centimeter, we do the UAG. If there is a size is less than 1 centimeter, multiple node, how do you proceed, sir, in that case?
So first of all, that is not called nodule, that is called as node. Okay, there is a great deal of difference between nodule and node. Nodule is thyroid nodule. Node is a node. Okay?
Yeah.
So a node which is less than 1 centimeter in lateral compartment, or for that matter in central compartment also. Central compartment literature varies. Somewhere they say 0.8 centimeter also. Please do not even put the needle to confirm whether it is metastatic or not. You don't need to do that, because it does not change the prognosis of the patient.
Yes.
And understand one thing, a node which is less than 0.8 centimeter in central compartment, it is not increasing in size, it is not leading to any change in your thyroglobulin level. What are you going to achieve by going in, apart from damaging the vocal cord of the patient? Okay. So a central compartment node or a lateral compartment node, if the size is less than 1 centimeter, you should, obviously, it is a structurally incomplete recurrence. You understand the point? It is a so in our dynamic risk stratification, it becomes a structural incomplete recurrence. Now there are various lines of management of structural risk. You will see multiple factors. You will also see the age of the patient, right? Yes. If you have the facility of seeing the mutation in the thyroid, you will see that mutation as well. So suppose it is a BRAF positive. Are we going to wait and watch? No. I'll go in and do the resection of that node. But if we know it was an initial low risk, now there is a suspicious node in central compartment. It is sitting bang on the recurrent laryngeal nerve. Size is say 7 mm. I'll wait and watch. I'll call the patient after. See, even with a 7 mm node versus a 1.2 centimeter node, the chances of injury of the recurrent laryngeal nerve is equivalent. Right? So anyway, I'll keep that patient in close observation, which is called as active surveillance, and I'll see whether the size of the node is increasing or not. If it is increasing, then only I'll think of going and doing a surgery. Otherwise, I'll keep the patient on follow. It was a very good question, actually. It was a very good question, and this question just signifies that you've read the literature as well.
Management-wise, that those FRMA tests while deciding in your practice, is there any clinical point regarding that? those tests?
See, yes. So this rule in and rule out is we are going to discuss in our next session.
Okay.
Because that is a very important point.
Right.
So, and this is a very elaborate topic. Okay. Rule in and rule out. So we are going to discuss that in our next class, and I'm pretty sure Dr. Shikha will be delighted to discuss that in our next discussion. Okay. So please do attend next class as well.
Sir, a doubt. Is there any situation where we should say that we can go ahead with an ipsilateral central neck dissection?
Where we can see there is no recommendation of going ahead with an ipsilateral central neck. Getting the point. So suppose you are doing a T1, T2 neck dissection of the ipsilateral of thyroid gland. Size of the tumor is say 2 centimeter, and you see that there are some nodes which are some blackish in color. In those situations, you can go ahead with a central compartment neck dissection. You send it for further section. You see whether they are positive or not, and you can base your call of contralateral central compartment based on that. Okay, but if that is a scenario for me, I'll upfront go ahead with a bilateral. See, it hardly takes 5 minutes to do a central compartment. Okay, if you do it properly, you just have to trace this nerve completely from top to bottom and remove all the tissues around it. That is a very simple procedure. So if you have any doubt, just go ahead and do a central compartment.
Yes, sir. Why I asked is there was a discussion here of ipsilateral, because in our institute we don't practice anything less than bilateral central. Like
exactly,
we don't have anything called ipsilateral. So I had a doubt.
Exactly.
Is there any situation where we are supposed to say we'll do an ipsilateral?
No. So ipsilateral neck dissection does not make much sense. So if you're do a complete bilateral, because see, if it comes positive, then you have to go in again in the central compartment. You will enter into a violated area. Why not better do in a vertical?
Yes, sir.
Hello. So if you're
that is the discussion here usually, where we are not allowed to ever say at all something called ipsilateral. Like the practice here
which
is
institute you
are
are in?
Sir, in Yerapaya Medical College, Mangalore.
Oh, perfect. Great. That's a wonderful thing to do. So that is what I also would recommend. That central compartment, if you're do a proper bilateral central compartment.
But theoretically, for exam's sake, do we ever, in any clinical scenario, have an answer saying ipsilateral central for the section?
See, thyroid pain, there is no one correct answer. You have to understand. You have to understand the philosophy of treatment. Okay? The philosophy of treatment is to maximize patient survival outcome and minimizing the morbidity. That is the whole philosophy of treatment. So suppose the last question that he asked is suppose 1 centimeter node. To understand, see, the evidence for that also is not very strong. If somebody wants to counter you, they'll say ki ATA ka recommendation is not really very strong about that. Okay? Or maybe the evidence is weak. You will see ATA always is weak evidence, strong recommendation. Strong evidence, strong recommendation, right? So go and read into these as well. But we have to understand the philosophy that we have to minimize our interventions, or we have to plan our interventions in a way that we harm the patient to minimum. So coming on to central compartment, we are addressing the central compartment. If you're already doing one side central compartment, how much time is it going to take you to do opposite side central compartment? You are doing it in a virgin plane. You will nicely clear everything. You know that you have done a wonderful job. Even if some disease comes over there in future with 6 centimeters of node over there, you will wait and watch. Because if whether it is 6 mm or 1.2 mm, the injury to the nerve is going to be same. Right?
Yes.
So these are important considerations. So see, regarding ipsilateral neck dissection, you will see literature. There are multiple recommendations from multiple centers. Some will say large thyroid nodule on the ipsilateral side. Go ahead and you can do an ipsilateral central compartment. But none of them are part of ATA recommendation. Okay. So if you look for literature regarding any line of management in thyroid which is being done anywhere, you will find everything. You will find even near total laryngectomy. Sorry, near total thyroidectomy somewhere. But these are now not a part of the recommendation. The idea is that if you are doing NTL, near total thyroidectomy, and if the disease in say colloid goiter, okay, and if that comes out to be positive, then you will have to go and do a dissection in an already violated bone. Okay? And we know that much of tissue is not really going to help someone in getting that the ultrasound required for the body. Understand the philosophy, right?
Yes, sir.
We are all here exam going, so we are full of questions, sir. Sorry for that.
Oh, please. I love questions.
Sorry. Kindly
No, sorry, please. Please. Thank you, sir. Thank you, everyone.